Okay, good afternoon, everybody. Thank you for joining us for our webinar today. My name is Claire Howard. I am a research coordinator at the National Collaborating Center for Methods and Tools, and I will be your moderator for the webinar today. Today's webinar, it features a story from our third issue of our casebook entitled The Development and Implementation of Standards in Prenatal, Postpartum, and Early Childhood Public Health Nurse Practice in Manitoba. And we are happy to have with us today Dr. Cheryl Cusack, Brianna Harms, April Gage, and Jody Unger. So before we begin, there's just a few housekeeping items. Please use the chat box to post comments or questions during the webinar. If you can't see the chat box in the panel on your right-hand side, you can open it by clicking on the speech bubble that appears when you hover your mouse over the slides, so towards the bottom. We recommend that you use a wired connection. If you're having connection issues, the WebEx helpline is on the slide. It is also 1-866-229-3239. And you can also post in the chat box if you're having an issue, and our support person, Vanna Dhaliwal, will make sure to answer you and get back to you about that. Also, if you can't hear anything, which you wouldn't be able to tell if I'm speaking, but if sound cuts out during the webinar, try clicking on the audio broadcast option, which is the little dot with brackets around it towards the bottom of your screen, and you can also access it from the Communicate tab. So if you're finding that you don't have sound and it cuts out during the webinar, you can try those as well. So after today, the webinar recording will be on our YouTube account, and the link is up there. And the slides are also available on our SlideShare account, and that will be available about 1 to 2 weeks after the webinar today. So we also have several polling questions for you today. The first polling question here is, how many people are watching today's session with you? A, just me, B, 2 to 3 people, C, 4 to 5 people, D, 6 to 10 people, or E, more than 10 people. I'll just give you a few minutes to answer that question. Okay, great. Thank you to everybody who answered. So our second polling question today is, have you visited the NCCMP's website or used its resources before? A, yes, or B, no. Okay, great. Thank you again to everyone who answered that question. And if you have visited our website before, how many times have you used our resources? Once, 2 to 3 times, 4 to 10 times, or 10 or more times? Okay, great. Thank you. So as I said before, this webinar is part of our peer-to-peer webinar series where we share stories about how people have used evidence in public health practice in Canada. So the National Collaborating Center for Methods and Tools is one of 6 national collaborating centers across Canada, and we're hosted at McMaster University in Hamilton, Ontario. And our goal is to support public health professionals and organizations to integrate evidence-informed decision-making into their work. So the National Collaborating Centers are funded by the Public Health Agency of Canada, and we each focus on a different priority public health topic area. From the west, there is the National Collaborating Center for Indigenous Health. I'm just seeing on the map right now it says NCC for Aboriginal Health. They have recently changed their name to the National Collaborating Center for Indigenous Health. We have the National Collaborating Center for Environmental Health in Vancouver, British Columbia, the National Collaborating Center for Infectious Diseases in Winnipeg, Manitoba, the National Collaborating Centre for Healthy Public Policy in Montreal, Quebec, and the National Collaborating Centre for Determinants of Health in Antigonish, Nova Scotia. So at the NCCMP, we offer many products and services to support public health professionals in engaging in evidence-informed decision-making. So this includes the Registry of Methods and Tools with over 270 methods and tools, online learning opportunities that include our 13 online learning modules, workshops, Public Health Plus, which is a repository of public health research, video series that include our Understanding Research Evidence videos, which go through concepts important to research in short and easy to understand videos. And we also do networking and outreach. So if you see us at a conference, come and say hi. So the webinars, this webinar series is based on our evidence-informed decision-making casebook. We're in the 3rd issue of the casebook right now and actually have over 24 stories in the casebook. So if you haven't had a chance to look at the casebook yet or read it, I highly suggest that. There's a lot of really great stories in there from public health practitioners on how they've used evidence in practice. So our presenters today come from Manitoba from a couple different organizations. We have Dr. Cheryl Cusack, who is the Acting Executive Director of the Population and Public Health Branch at Manitoba Health, Seniors and Active Living, and a sessional instructor at the University of Manitoba. Past work experiences have focused on public health practice in areas of nursing leadership, management, government, and direct care. Work and academic interests include public health practice, nursing role development, health equity, and interprofessional collaboration. Cheryl is the current president of the Community Health Nurses of Canada. We also have Brianna Harms, who works as a PHN, or public health nurse, and a resource coordinator for public health in Killarney, Manitoba. She has worked in a variety of areas, including rural acute and long-term care, Brandon emergency, URIS, and primary recovery. She completed her LPN and RN in rural settings and finished her BN by distance education. She currently lives in Killarney with her spoiled dog, Asha, who you can see in that picture, a very cute little dog. We also have Jody Unger, who graduated with honors from the University of Manitoba in 2006. She worked in public health since 2006, starting in Southeast Health, and upon amalgamation with Central Health, has been with Southern Health Santé Sud. Jody is the Regional Perinatal PHN and SHSS since the position was created in 2014. She is also an international board-certified lactation consultant. And finally, but not least, we have April Gage with us today. She is a public health nurse in the Interlake Eastern Regional Health Authority in Manitoba. She has a strong interest in population health and health equity and has been an active participant in the development of the public health nursing standards and pathways. April recently completed her Master's of Nursing with a thesis topic exploring a community-based mental health promotion strategy for families. So without further ado, I'm going to pass it over. I believe I'm passing it over to Brianna. So, Brianna, you should be...
Sorry, I was muted. Hi, guys. Welcome to today's webinar. The 4 of us presenting today would have been involved from the outset of this initiative. But before we get started, we would like to recognize the many other public health nurses and public health leaders who worked on various components of this initiative. In particular, we would like to acknowledge the leadership of Jan Schmallenberg and Michelle Johnson, without which this work would not have been possible. So we'd like to start off with the polling question. This presentation is focused on public health nursing standards. So we are interested in understanding the roles of individuals joining the webinar. Which of the following areas most closely align with your work? Nursing, health promotion, primary care, management, research, and other. So I'll just give you a couple minutes there to fill it out, and we'll see who we have most represented. So it looks like we have mostly nursing, but we have some from health promotion, primary care management, and research. So that's great that we got a wide variety of people. So this presentation will describe the process undertaken in Manitoba to increase consistency in public health nursing prenatal, postpartum, and early childhood practice. The process was initiated in 2013 as an idea of the Provincial Managers Network. A lot of work has taken place since that time, but implementation remains ongoing. Today we will describe what has taken place, the outcome and tools developed, and the engagement required at multiple levels, and methods used for evaluation at multiple points. The background and justification to begin this work was the variation in public health nurse practice. At that time, in 2013, competency-based standards specific to the public health nurses in the perinatal health period did not exist in Canada. In the literature, national experts had also identified role clarity and the development of a common vision based on the full scope of public health nurse practice a priority. In response to this issue and in consideration of the local context, Manitoba developed provincial public health nurse standards. These standards, launched in 2015, built upon national documents by the Community Health Nurses of Canada and the Canadian Public Health Association. For these reasons, while the Manitoba standards reflect the provincial context, they may be of broad interest to others in Canada. According to the Community Health Nurses of Canada, standards represent a vision for excellence and articulate measurable public health nurse benchmarks. The short-term objectives of this initiative, therefore, was to develop consistent and measurable activities for public health nurse roles in prenatal, postpartum, and early childhood practice. The long-term outcome was development of tools and resources to support implementation and attainment of the standards by all public health nurses in the province. A provincial paraprofessional home visiting program was a component of Manitoba public health practice, so it was reasonable to aim for greater consistency in the other components of perinatal public health nurse work. The development of the provincial standards was the beginning of this initiative and work in Manitoba. Perinatal standards were critical to depict the role of the public health nurse in promoting health equity in a population-based early childhood practice. The model for evidence-informed decision-making in public health was used as a framework. The National Collaborating Center states evidence-informed public health depends on sound evidence, which involves integrating the best available research evidence into the decision-making process. Additional factors, community health issues, and local context, community and political preferences and actions, and public health resources create the environment in which that research evidence is interpreted and applied. This model was crucial in guiding numerous workshops, webinars, and the process over the years to come. It helped us to frame and consider different types of evidence and challenged us to remember that public health evidence is more than randomized controlled trials. While those are important, a key finding was the importance of the local context, experiential knowledge, and application of the research based on community and political preferences. It was identified that an important first step would be developing a common vision. A key component of developing that shared vision was consistent understanding of concepts. There had been an erosion of the public health nurse role in practice, and it became clear that complex concepts such as population health, primary health care, primary and medical care, and universal versus targeted programs and services were not understood in the same way. To work to full scope in a population-based practice, public health nurses had to understand the distinction between these concepts and be deliberate in their daily clinical decisions. In Manitoba, based on the Families First Home Visiting Program, a universal screening tool has been tested and proven to identify individuals who would benefit from focused public health interventions and follow up to promote population health and equity. Conversely, individuals who are knowledgeable and capable of accessing primary care and or medical care independently could be referred by public health nurses for their health care services. I will turn it over to Jody to continue with the initiative.
Thank you, Rihanna. Public health expertise was gathered using a variety of sources of evidence. In the following section, we will outline an example of how the model and information was used to develop the standards and greater knowledge of the public health nursing role. Canadian researchers above describe optimal attributes to support public health nursing practice under headings of macro, meso, and micro. The macro level refers to government. The Manitoba Public Health Branch provided leadership and funding to support the project. A frontline public health nurse, Michelle Johnson, was hired to lead the project and provide provincial coordination. The meso level refers to the local organizational culture, including values and leadership characteristics. Multiple stakeholders were included on an ongoing basis. There were multiple workshops, advisory groups, and teleconferences. Different forms of communication were utilized. That included newsletters, emails, and feedback to develop a shared vision. Lastly, the micro level pertains to the day-to-day management practices. Public health nurses from across the province informed the development of the standards. Work time was allotted for participation. Public health nurses were supported to attend workshops and participate in teleconferences, and the project team traveled across the province. The focus was competency rather than task-based and promoting autonomous full scope of public health nursing practice. The evidence-informed decision-making, EIDM model, was used at multiple points over the years. The next few slides provide examples of how the model was used. The EIDM model identifies the 4 areas that contribute to public health expertise. The first we considered was community/political section. Manitoba has a unique geography and population demographics. The population of Manitoba has been growing annually and is now just under 1.4 million. A few fun facts: Manitoba has a diverse geography which extends from the 49th to the 60th parallel. That is an area close to 650,000 square kilometers, or the distance from Paris, France to Oslo, Norway. Manitoba is larger than the country of Japan and twice the size of the United Kingdom. So when we think of public health nursing practice across the province, that's a huge area to cover. While the geography is vast, Winnipeg is the largest city, accounting for close to 2/3 of the population of Manitoba. Culturally, Manitoba is also extremely diverse. Immigration is one strategy for population growth, which has brought more than 130,000 newcomers from around the world to Manitoba in the last decade. Lastly, of all the provinces, Manitoba has the highest proportion of Indigenous people per capita in Canada, which is young and a growing demographic. In terms of political considerations, similar to other Canadian jurisdictions, Manitoba is in the midst of health system transformation. Recent reports identified that for a province the size of Manitoba, our health system is overly complex, expensive, and not achieving expected outcomes. Regional health authorities will focus on being excellent service deliverers, aligned with a provincial clinical and preventative service plan, and divest functions most effectively and efficiently served in a provincial shared health organization. If we think back to the geography slide, with 2/3 of the population living in Winnipeg, the outcome has been that the majority of health services are situated in Winnipeg. Manitoba Health Seniors and Active Living will focus on policy and planning, funding, and oversight of the provincial health system. The next component of the EIDM model used was community health issues and the local context component. There are many headlines like this one. Manitoba gets poor grade in Canadian Health Report. The article goes on to say that Manitoba ranks near the bottom of a report on the state of Canada's health system. This Conference Board of Canada report, which looked at disease rates, obesity, infant mortality, and habits such as smoking and sedentary lifestyle, gives Manitoba a D grade. These topics are all important population and public health topics where public health and nurses could make potential impacts. The local context can further be understood using surveillance data, community health reports, and peer-reviewed literature. When considering maternal and child health in Manitoba, there is an abundance of data identifying gaps based on socioeconomic status. For example, while national rates of smoking during pregnancy are decreasing, rates in Manitoba are increasing and well above national averages. Manitoba has disproportionate rates of teen mothers. 1/3 of teens reported drinking alcohol, 1 in 5 used illegal drugs, and close to 50% smoked cigarettes. Manitoba's negative birth outcomes, such as low and high birth weights, are more prevalent among teenage mothers. Some of the highest rates of neonatal, infant, and childhood deaths across Canada are reported in Manitoba's lowest income quintiles. Manitoba also has some of the highest rates of children in care in the world. Indigenous children represent 26% of the population, but more than 90% of kids in care. Contrary to the previous slides, we know that there is substantial research that the early childhood period is critical in setting the trajectory for lifelong wellness. The Center on the Developing Child at Harvard University has an excellent website on healthy child development and the impact of adverse childhood experiences, or ACE indicators of toxic stress. There is irrefutable evidence that positive early experiences are necessary for sturdy brain architecture and the development of skills and learning capacities. Many of these components are applicable to public health nursing practice. Child poverty is a powerful determinant that perpetuates intergenerational inequities. The most important protective factors are development of a nurturing environment, healthy attachment, and the promotion of equity from the start. Manitoba data highlights risk of failing to take action. A Manitoba Centre for Health Policy study looked at Families First data from all children born in Winnipeg from 1984 to 2003. On the bottom of the graph at the right, you can see social risk factors, which they compared to clinical risk factors, such as prematurity. The study concluded that social risk factors for subsequent hospitalization and scholastic failure are as threatening as, and more common than, routinely documented biological risk factors. In promoting healthy child development, public health nurses must incorporate social indicators of toxic stress in their health assessments. I will now pass the presentation over to April.
Thank you, Jody. Public health resources are the final component contributing to public health expertise. In Canada, we have national bodies that shape the provincial resources. As you can see, this is a recent infographic from the Chief Public Health Officer of Canada, which outlines her vision and priorities. The National Public Health Office advocates for the reduction of health disparities in Canada by focusing on the needs of the poorest and most marginalized Canadians. The ultimate goal is to help level the playing field and contribute to all Canadians reaching their optimal health. The areas identified on the right are for prevention and promotion, and on the left, action on factors influencing health are addressed. Dr. Teresa Tam, the Chief Provincial Public Health Officer, states, social determinants of health, such as income, have a bigger impact on our health outcomes than genetics, the healthcare system, or most healthcare services. PHNs represent the largest group of public health practitioners, and action on the social determinants of health is foundational. Full scope is based on a population-level practice achieved by working in collaboration with other professionals and agencies and incorporating a social justice approach. This practice has been outlined in a number of documents developed by the Community Health Nurses of Canada. These include standards of practice and professional practice model, as well as competency documents and a roles and activities document. Competencies are defined as the integrated knowledge, skills, and attributes required of a public health nurse to practice safely and ethically. Attributes include, but are not limited to, attitudes, values, and beliefs. While we have documents articulating the public health nursing roles, literature depicts a lack of clear vision and advocates for role clarity. This incongruence represents a significant theory-practice gap. In addition, population-level practice is often constrained by under-resourced organizational structures that prioritize clinical and curative services. In the Roles and Activities document, the Canadian Public Health Association provides the following definition. It states that a public health nurse has a baccalaureate degree in nursing and is a member in good standing of a professional regulatory body for registered nurses. The public health nurse combines knowledge from public health science, primary health care, which includes the social determinants of health, nursing science, and the social sciences. Public health nurses also focus on promoting, protecting, and preserving the health of population. They link the health and illness experiences of individuals, families, and communities to population health promotion practice. Public health nurses also recognize that a community's health is closely linked to the health of its members and is often reflected first in individual and family health experiences. Recognizes that healthy communities and systems that support health contribute to opportunities for health for individuals, families, groups, and populations. And lastly, but not least, they also practice in increasing diverse settings, such as community health centers, schools, street clinics, youth centers, and nursing outposts, as well as with diverse partners to meet the healthcare needs of specific populations. It was the culmination of these sources of evidence that aided us in developing the standards. The Manitoba standards were published in 2015. However, the long-term vision was the supplementary tools necessary to support their implementation and create practice shifts. These are shown here and available in the Manitoba Health website. The core document articulates the minimum standard practice expectations for public health nurses. Supplement 1 illustrates standard statements and practice expectations at the individual family level and the community population level. Each practice expectation is linked to a public health nurse competency statement. As you can see, Supplement 2 includes multiple documents and webinars to support public health nurses in their implementation and attainment of the standards. It includes forms from public health nursing assessment and documentation, which are used in conjunction with evidence-informed care pathways. Detailed instructions, evidence-based information, and access to resources, as well as services, is contained in each document. These documents were originally from BC, and then they were reviewed, adapted for Manitoba, and piloted by the public health nurses across the province. Provincial, if we look at the provincial webinar series of Manitoba Public Health Nurses, a final implementation component was a series of webinars to disseminate information across the province. Public health nurse champions participated in the development of 4 webinars. They were held between August and September of 2018. The first webinar provided the background and context, recognizing that the project had been ongoing for several years. The second webinar focused on prenatal, the third on postpartum and newborn, and the last on documentation forms and processes. Again, the EIDM model was used as a framework to guide the webinar content and development. The webinars were recorded and are available on the Manitoba Health website, along with the supporting documents. Public health nurses continue to access them, and they are used in the orientation of new staff. Evaluation was incorporated throughout. However, 2 of the formal methods will be discussed further. Before publication of the standards in 2015, survey data was gathered using a modified Delphi technique. The survey consisted of all of the standard statements, followed by a 5-point Likert scale. Participants were asked to rank their level of agreement with each statement, and boxes were also provided for written text. The intent was to have 3 survey rounds to revise and gain consensus on standard statements with less than 70% agreement. However, the results after the first round found that 90% of participants agreed or strongly agreed with the majority of the statements. The few statements where levels of agreement were in the 80% range pertain to timing of public health nursing follow-up. Comments in the text boxes reflected concern with the ability to meet the benchmarks within existing resources as opposed to the content of the statements. As there were no statements with less than 70% agreement, subsequent rounds of the survey and revision to the standard statements were not required. On the first round, there were about 250 respondents, which we believe is a very high number of public health nurses and managers in Manitoba. Another method of evaluation took place during the webinars. During each of the 4 webinars, participants were asked by polling questions to gauge their readiness to implement the standards based on the ADKAR model. We use the ADKAR model of change management to gauge public health nurses' readiness for change to the new standards. The model, which provides a detailed description of how an individual successfully moves from their current state to their future state. The future state that we were aiming for was a more consistent public health nursing practice based on those provincial standards and supporting tools and documents. Consistent with the earlier feedback, participants generally reported that they had the knowledge to implement the standards. Methods to evaluate the impact of standards in practice are under development. Now, I would like to pass things on to Cheryl.
Thank you very much, April. So this is an example of one of the polling questions that we used based on the ADKAR model. And for every webinar that was done, we adapted the questions so that it fit accordingly. The polling questions are a fun way to engage the audience during a webinar, but they also provide really useful information going forward for a team. In general, participants reported that they had awareness and desire, and in most cases knowledge, but depending on what was being evaluated, that varied somewhat, to implement the standards in their perinatal practice. So moving forward and imparting that knowledge was helpful in each webinar. So this is another example of a polling question that we used in the webinar. And based on our discussion today and considering public health nursing practice from the population perspective, we want to open it up and have you also answer this question about where public health nursing and public health interventions have the greatest population impact. So is that long-lasting protective interventions, changing the context to make individuals' decisions healthy, counseling and education, socioeconomic factors, or clinical interventions? So we'll just give you a minute to answer that question. So the responses are coming in. So people are thinking about this, I think, a little bit. That's good. Oh, we've got, you can see the answer there. The responses are a little bit split, but the majority for sure definitely recognize the correct answer. So we followed up with this pyramid by Friedman, which many people may be aware of. It's a 5-tier pyramid that best describes the impact of the different types of public health interventions and provides a framework to improve health. At the base of the pyramid, indicating interventions with the greatest potential impact are efforts to address socioeconomic determinants of health. And that was the answer that many of you reflected in your decision. In ascending order are interventions that change the context to make individuals' default decisions healthy, clinical interventions that require limited contact but confer long-term protection, ongoing direct clinical care, and health education and counseling. Interventions focusing on lower levels of the pyramid tend to be more effective because they reach broader segments of society and require less individual effort. Using a common analogy of the stream, these activities would be considered the farthest upstream, with those at the top more downstream. On the right-hand side of the slide, I've proposed public health nursing interventions that I think align with the pyramid, and I'm open to having more discussion about these. So if you'd like, go ahead and use the chat box if you have comments, whether you agree or disagree with that, with the list that's been specified here. So throughout the process of developing the standards and the webinars, we challenged participants in Manitoba, public health nurses, to consider the standards and a wide variety of evidence that was integrated as a result of the evidence-informed decision-making model. The aim of public health nursing practice is to promote population health through work with individuals, families, groups, and communities. We want to be working at the base of the pyramid. In applying the national depiction of the public health nursing role to the Manitoba context, this includes understanding the community and using our Families First Screen and Parent Survey process universally to determine where to target public health nursing perinatal activities based on foundational values of public health practice, in particular equity and social justice. Working in interprofessional teams requires understanding of roles and responsibilities. And this diagram shows a Venn diagram where there's a bit of an overlap, but for the most part, the services of PHNs do not align with the healthcare needs of individuals in the prenatal, postpartum, and early childhood populations. In essence, most work at the individual level is providing clinical care or education, which is classified as primary care. Primary care focuses on preventing, diagnosing, treating, and managing healthcare conditions. Primary care requires collaboration among health professionals and, of course, is an important aspect of healthcare services. In considering lessons learned, clarification of the PHN role in perinatal health is essential. Public health nurses must be deliberate in determining where there's value added from public health nursing interventions and where public health nursing practice is situated within a whole system primary care approach that's collaborative, interprofessional, and integrated. The model for evidence-informed decision-making assisted us in framing the public health expertise for perinatal practice in Manitoba. The evidence highlighted growing gaps in equity experienced by certain populations and many concerning outcomes for families in Manitoba that are continuing to worsen despite access to primary care. This picture and document developed by the National Collaborating Center for Determinants of Health identifies upstream, midstream, and downstream activities. And public health nurses engage in all of these activities and must consider the range of evidence and activities that go beyond the care of the individual to promote the health of communities and populations. The value added and unique component of the public health nursing role in the health system is the upstream population-based work. So in wrapping up, we learned a lot from the process of developing these standards and this ongoing work. The collaboration of all public health stakeholders, and in particular, the expertise of the public health nurses was essential in developing public health expertise and a shared vision for public health nursing practice. PHN, or public health nursing practice, is multifaceted, but it needs to be evidence-informed and consistent provincially. To develop arguments regarding the value of the public health nursing role, we need to be working upstream and population-based. Public health nurses are the only nurses working at that population level, and we need to keep thinking about this and how to have the greatest population impacts within the entire spectrum of healthcare services. Population-level work depends on narrowing the gaps between those who are most and least healthy, which means public health nursing practice must value and be always grounded in concepts of equity, social justice, advocacy, and community leadership. Standards were necessary in Manitoba to start this work. However, public health nurses work in complex systems and organizations, and we've learned that change takes time and multiple approaches. So thank you for joining us today, and I want to acknowledge the fantastic work of the nurses that presented here with me on the line. They've been champions who've led this work across the province and have contributed to the great products that we have today. So I'm happy to take questions, and the final slides are of the references that were included throughout the presentation. So I will pass it back now to Claire.
Great, thank you. So if anyone has any questions, please put it into the chat box and we'll make sure to get to that. And please send your questions to all attendees, and we'll make sure to see that. So I guess just to start, while we're waiting for some questions to come in, I have a few. So I was reading over the story again that's in the casebook, and you had mentioned that methods to evaluate the impact of the standards were under development when the story was published. Do you have any updates about that you can give on the evaluation?
Yeah, that's a really good question, and we're still in the process of having those methods for evaluation being implemented. We're actually moving towards an electronic medical record in Manitoba that is within a component of our transformation. And right now, we don't have a consistent public health nursing record across Manitoba, so we have put that a bit of the evaluation on hold a little bit while we're moving towards that electronic system, and then we'll have a better ability to be able to draw that data.
Okay, that's great. And because at the National Collaborative Centers, we have a national audience. So one of my questions is always, how do you think this could be applied in other provinces or territories, or what do you see that could be useful for other provinces and territories to know about this?
That's a great question too, Claire. And the reason that these standards, I think, are applicable to all across Canada is because we built on the national work that's already taken place. So all of the Community Health Nursing of Canada work, standards, discipline-specific competencies, leadership competencies, they originated from work that was done from the Canadian Public Health Association and core competencies. So we very much built from that national work, which is applicable to national audiences. And while some of the unique components of our provincial program pertain to the Family's First Home Visiting program that we have in Manitoba, there's also home visiting programs and similar work across Canada. So those public health nursing competencies and foundations should apply beyond Manitoba. And I think that, just based on some of the national work that I do, I think all provinces and territories are struggling with some of the same questions, and managing that balance between those universal and targeted services, and particularly things like birth volumes, which continue to rise, are things that continue to challenge some of the work that takes place, and the importance of being able to determine the targeted follow-up that public health nurses will have to promote population health outcomes.
Great, thank you. I have actually just one more question. So if you were to start over, which I know is probably a scary thought, is there anything that you think worked really well about the process, or is there anything that you would do differently?
Yeah, that's another really good question, and I think that what would we do differently? I think one of the challenges has been that we've been at this work for a very long time. I think if we could do something differently, I think that this project stayed on the radar of everybody because it was very important. It was done often with competing challenges that, when we think about that political environment and the community environment, lots of other things going on that created different ways to prioritize, but this was always kept as a priority by all participants in our province, I think, which helped that work move forward. But the dedicated work, when there is actually staff dedicated to this work, is when you really can see that that work can get done. And we've had some gaps in those in that time where there has been dedicated resources. So that is certainly one thing that could be done differently to move it forward. That being said, though, I think it's also sometimes it takes a shift in thinking when we're talking about equity and changing practice and looking at things differently, and sometimes time, I think, is helpful in that. So I don't know if I really answered your question, but I think that, you know, sometimes, so I think sometimes doing things, the need to get things done quickly, you can complete a project, but that actual knowledge translation and uptake sometimes benefits from that time too.
That is really great. So I just wanted to say thank you again to Cheryl and Jody and April and Brianna for presenting today. We just have a few more conclusion slides. So if you're using EIDM in your practice or evidence-informed decision-making, we want to hear about it. So please email us at nccmt@mcmaster.ca. Or if you need support for evidence-informed decision-making, we're here to help as well. So again, that email address is nccmt@mcmaster.ca. So we have a few final poll questions for everyone today. The first question is, participating in this webinar increased my knowledge and understanding of the application of evidence-informed decision-making. So strongly agree, agree, undecided, disagree, strongly disagree. I will use the tool or method from today's webinar in my own practice, so strongly agree, agree, undecided, disagree, strongly disagree. Which of the following statements apply to your experience with the webinar today? And you can select all that apply. The webinar was relevant to me in my public health practice. The webinar was effectively facilitated. The webinar had opportunities to participate. The webinar was easy to follow along. And the webinar met my expectations. And the fourth question, can we contact you in the future to discuss how we can improve our webinar series? So yes or no, and then if yes, can you please give us your name and your email address? So I'll give everybody a few minutes to fill out that feedback. And if you have any more questions, please feel free to put them in the chat box, and maybe we could email them to the presenters today, and we can answer your questions for you. So I'll give everyone a few minutes there for the feedback. Okay, great. So looks like everyone's responded. Thank you to everybody who responded. We really appreciate your feedback. It helps make our products and our webinars a lot stronger. So we have a few upcoming webinars. So we have the online course for health impact assessment, a tool for developing healthy public policy. So the webinar will be on that new online course. And then the next webinar in the peer-to-peer webinar series is about evidence-based food handler legislation from a story from York Region, and that is at the end of February. So if you're interested in those, please check them out and register for those webinars. And then this is just a list of webinar series that we offer here at the NCCMT. So we have the Spotlight on Methods and Tools, topic-specific methods and tools, an online journal club, and the peer-to-peer webinar series, which this webinar is part of. So thank you for everyone who joined us this afternoon, and thank you again to Cheryl, Jody, April, and Brianna. Just on a personal note, I know I really love seeing how the NCCMT's model can be used in practice, so that was really exciting to hear about that. So thank you to everyone who joined us today, and I hope you all have a great day.